and Honorable Royal Dr. Roy Abraham and Dr. Prasanjit Ghosh were chairing a session of Dr. John Allen, sir. So please.
Dear friends, we have a very distinguished speaker, John Allen, who is Professor John Allen, who is the president of the Royal Australian and New Zealand College of Psychiatry, RANCIPS, which is, we have a very special relationship with RANCIPS because the presidents of the RANCIPS, you very often come here for IPS meetings. And it's especially very important for me because as a Secretary General of WPA, our president, Helen Herman, is from Australia, and she is here, and we have in IPS and Royal College have a very special relationship. I also see the past president, Malcolm, here, and the president-elect, Vinay, also here. She's also Executive Director of the Mental Health, Alcohol, and Other Drugs Branch, Queensland Health. Vinay Lakra, would you like to say something about John? Yeah.
He's going to come up.
Fine. I think you can proceed.
We can start. Thank you very much. Good afternoon, everybody, and thank you very much for inviting me. It's been very great to come to India to this conference. It's been so many people. It's much busier than our conferences, so enjoyable. And as Dr. Roy said, we have a very special relationship between Australia and India. When I started working in the country in Australia, working on rural practice, 50% of the psychiatrists who worked for me came from India. And one of the issues that they had was that in this age of global psychiatry and of transmission of qualifications and trying to find a standard, many doctors would come to Australia and work. They would have a great deal of difficulty passing the Australian exams. Even though they were very good doctors and well trained in India, there was a lot of problem for them in gaining their qualifications. We've also talked a bit about brain drain and other stuff, and I'll talk about some of those things as well. Next. But I'm just going to talk about what we have done to try to make that experience easier and fairer for doctors who come from other countries to Australia. And perhaps that might be a model for some of the things we talked about today in the global mental health, about how we might be able to move qualifications around and work together. So in Australia, and I know that there is over 6,000 psychiatrists. We have over 6,000 members. 1,700 are training to be psychiatrists, and so there are about 4,000 practicing psychiatrists for 30 million people. You might think that's not very many. It's a lot of psychiatrists for not many people, but we still actually have problems, as we talked about earlier, in a gap between people getting into practice. About 85% of psychiatrists are fellows of our college, although in New Zealand only about 50% are members. And our college is responsible for the training, educating and representing psychiatrists in Australia and conducts all of the assessments for fellows. So it's not done through universities, but the training and the exams are done by our college. And of course, we have increasingly strong ties with many countries in the Asia-Pacific region, and we're trying to correct some of the issues of the past where I think Australia was not necessarily Asia-oriented and not always fantastically well regarded in terms of attitudes about countries of origin and frankly sometimes racist. So we have many psychiatrists come from overseas, and of those 6,000 fellows in the last 2 years, 1/3 of all the people who gained fellowships, so about 200 of the people who gained fellowships came from overseas, and the majority of our affiliate members in New Zealand are from overseas as well. So it means that in Australia, lots of services recruit psychiatrists from outside of country, overseas trained psychiatrists, and give them an area of need status because they can't get an Australian psychiatrist to work there. And these are the countries that people come from, which I think is quite interesting. So from us, in the last 5 years, India, second largest, and the largest if I can get it to happen, it doesn't want to do that, is the UK. But of course, many of those psychiatrists actually come to the UK via India. And so, in fact, a lot of the psychiatrists who come to us from the UK are actually of Indian origin as well. And a small number from Sri Lanka as well, I think you probably noticed there. A small but significant number. In 2006, the Australian government made a couple of changes. One was that they wanted everybody who practiced as a specialist in Australia to be a member of the Specialist College. And the reason for that was about standards and about quality, that they were very concerned that people who weren't in a college did not have enough CME, continuing medical education, and not meeting enough standards. And also that they changed the way that we did the assessment process for overseas doctors. It resulted in a number of new pathways. I'm going to talk about some of those pathways today. There are three main pathways for overseas doctors who come to Australia to practice. The first two, one about people who wish to just use general practice, and the third one is about specialists. The first one's what's called a competent authority pathway, which means that you can have exams that are recognised, a bit like people who trained in the UK. This is called number two is a standard pathway for people who do an exam for the Australian Medical Council, which is a bit like the PLAB in England. And the third one is a specialist pathway, which says that the person has to be comparable to the standard of a specialist trained in that specialty in Australia. So it means that we look to see whether the people coming have the same standard as psychiatrists. And these pathways always include something about having an English language proficiency, some sort of primary source verification, which is now international, assessments against position description, a period of supervision, assessment of continuing performance development, and then assessment of performance. In the past, as I've said, these have always been examinations. And because of cultural and language differences, it's been quite clear that a lot of doctors who are very good have trouble passing those examinations. So what we did was change things so that we would have a specialist pathway to help people who came from overseas to get fellowship. So we took in people who had the highest specialist qualification in their country at the time of qualification, who had attained registration in that country and who wished to work and remain in Australia, and that they had a job on offer. So we always looked at so we started to look at the institutions where people came from and looked to see what the quality of their training was. We not just looked at the institutions, we looked at the country as well to look at the quality of services and the type of regulation and standards around that training. So, for example, for Indian services, we stopped accepting people who had DPMs, but we looked for MDs from proper institutions. And essentially, this slide shows that under this pathway, you make an application, various things happen. There are three possible outcomes, which are here, that you could be substantially comparable, partially comparable, or not comparable, which means you go back to training. But for substantially comparable, meant that that doctor was as good, this training and practice was as good as, the same as the Australian doctors. All we had to do then was prove that they were good enough that was the case. And so we started to, as I said, look at the things in different countries. We're particularly interested in training standards, whether or not there was external accreditation of the training. And for us in Australia, that means we have an external body, the Australian Medical Council, that looks at all of our training standards. What the system was like, so the way that people practiced and the system they practiced in, their experience as a consultant psychiatrist, and whether they had other qualifications like PhDs and research and so on that would help them to do that. We set up a panel, we worked a way of making a score, and were able to accept people into a pathway. And if they were seen to be comparably assessed, we took them on. And so in the previous situation, people who'd come would be very experienced psychiatrists, but they mightn't have done an exam for 20 years. Their training wasn't always suitable. They had a lot of cultural adjustment. They got demoralised and found that after 7 or 8 years, they still hadn't passed the exams and were working mainly as wage slaves rather than doing the thing that they were trained to do. And our mechanisms of support were not very good. So what we started to do was we gathered a group of people that we thought would be equivalent, and we set up a pathway that would prove that equivalence and put them on that. The first one was started in 2011, called Phase 1, and Phase 2 we reviewed it and got some further rules around more people who'd be eligible for qualifications. I'll go into what the panel looked like. So the first we only started with just a small group of people who, from our experience in our exams, had passed them quite well. So people who had a CCST from the Royal College, MRC Psych from long-standing, people from Canada and board certification in the USA. They were recognised as suitable training programs. The New Zealand Medical Council had done some work with them at a high success rate in our exams. And the pathway that we created had a number of elements to it. And it was based particularly on workplace-based assessments, so no more exams, so you didn't have to go and be examined anymore. Started with a 3-month job orientation, and then we started 12 months of continuous assessment. So they had a supervisor and a trainer who gave feedback on what they did. We would go into their practice, and they would supply some cases that were worked on, and people like myself would go and have a consultant-to-consultant discussion about the quality of their practice and what they were doing, and start talking about how consultants made decisions rather than treating them like registrars and giving them an exam, and discuss their cases. And we had a 360 feedback, which I'll talk about in a little bit more in a moment, and then reports from supervisors. So we used a multi-source feedback, not unlike the one that's used in the UK. And we were able to, from their co-workers, from patients and families, from the candidate self-assessment, we were able to cover all the CanMeds things. And one of the most interesting things that we've found is that patient and family feedback on the doctor's performance is probably the most accurate predictor of whether or not they're actually a good doctor. I'm going to hand over to my colleague, Dr. Vinay Lakra. At the time, I was the chair of this group and we devised all these things, and Vinay was one of the serious workers on the group, so I'm going to let him present some of the data. Vinay is the President-elect of the Australian New Zealand College of Psychiatrists. Vinay.
Thank you, John. So just to add a little bit to what John has presented, I went to Australia in 2004, and I went through the exam system. So this system was not in place at that time. And I had the fortunate experience of getting some good advice and support from colleagues who had been there before. And thankfully, I was able to get through the exams quite quickly. But what we realized then was that there were a number of people, especially the senior you were, more likely you were going to struggle with the exam process. Because the exam was not really looking at that you are a psychiatrist of 10, 15 years experience. The exam is looking at your performance as a just recently qualified psychiatrist. They want you to do things in a proper way. And so when we noticed that, I thought the best thing was to get into the college and look at our systems and what we can do to support those people. Because there were people who'd been there for 10 years, 12 years, and they hadn't passed the exam. So now they had kids going to school, they had bought houses, they were citizens of the country, and some of them were in that situation where the medical board said, well, we were not going to register you, and they had no other career other than just go back to their country of origin. So the college actually started to do some of that work, and this is the result of some of that process. So when we looked at the first set of qualifications, there were quite a few people who were very unhappy about why is an Indian qualification not included in phase 1, or why is the Sri Lankan qualification not included in phase 1. And as John said, our effort was to look at things which were very similar to Australian training. The other thing which we looked at was performance in the examinations. And what we found was that people who'd done the MRC Psych with CCT, their performance was close to 85% success in the exam in first attempt. So that itself was proof enough that their training was very equivalent to the training being provided to people in Australia. And so once we started the process of, once we went through a process of identifying who is substantially comparable and went through these 3 phases, they were not necessarily different phases. But what they looked at was the numbers. It was not possible for us to have everyone going through the pathway at the same time, because the pathway over a 12-month period was quite intense in terms of resourcing. You have to understand, there were psychiatrists who were working in some of the rural and remote areas, and so somebody had to go from somewhere else to have that case-based discussion with them. And some of those discussions took the entire day, because the discussion was around an hour, but the flying time and reaching there and going back actually took a whole day. So you can see the numbers. There was only one in phase 1B who did not succeed, and there were 2 people who withdrew. The people who withdrew had issues primarily because they either got into some problem at their employment because of complaints process, and the employer actually withdrew support from them. But vast majority of them actually succeeded through the pathway without any problems. And so this slide really talks about the numbers right from 2014. So till September 2019, and you can see there's only 5 people who haven't succeeded out of 216 people. So what really we took from this is that our processes of assessing people and working out whether they were substantially comparable to an Australian trained psychiatrist were actually working. Because if they were not working, then we would see more people failing through this process rather than succeeding. And somewhere, I can't remember the exact time, but I think somewhere around 2016, we expanded from the initial 4 qualifications. So the UK qualification, the American qualification, the Canadian qualification, we expanded then everyone. There's quite a bit of information on our college website in terms of what we look at when that comparability assessment happens. And that comparability assessment is not just the College of Psychiatry, it's actually mandated by Medical Board and AMC for all specialty colleges. So if you're a surgeon and if you want to migrate to Australia, you have to apply to the College of Surgeons, and the College of Surgeons will go to something very similar process and say whether you're substantially comparable to an Australian trained surgeon or whether you're partially comparable or you are not comparable. And that will lead you to kind of some sort of pathway, whether you need to do some exams or whether you need to only do a 12-month supervised practice. So this subsequent cohort since 2016 includes people who've come from India and a number of other countries, and we continue to see that the pathway is actually quite successful and not that onerous what it was in terms of the examination process which was there previously. There are quite a few advantages to this whole approach in terms of assessing people. One of the things, as I said, is what we found was the more senior you were, more disadvantaged you were with regards to the exams. People who are relatively junior in their training and experience, who'd done their exam 2 or 3 years before they migrated, they were actually quite attuned to what was happening in examination and assessment process, and they were able to accept that feedback and move on and adapt better. Whereas more senior people were actually quite difficult, they faced quite a bit of difficulty in the examination process. So what we found was that that the assessment had a different types of assessment. So there was a supervisor assessment, there was a case-based discussion with an independent psychiatrist who came in to have that discussion with you. We don't really call that case-based discussion an exam because we don't say that it is an exam, it is a collegiate discussion with a colleague. But you have 3 of those, and so there are 3 different psychiatrists who come over and do that workplace-based discussion with you over a period of 12 months. So it really assesses you what actually you are doing in your workplace, in your work environment, rather than an artificial setting, which is similar to an exam process. Supervision, again, it basically means that there are a range of views you get from consumers as well. We've obviously seen that as the numbers have gone up, our reliability has increased. People are becoming more familiar with the process. It integrates quite a few competencies and provides an overall judgment about their practice. And certainly, especially with the 360-degree feedback and supervisory report, it captures a range of things, including how you work within a multidisciplinary team, what's your professional behavior, and plus with the 360-degree, they do their own self-assessment as well. So really, the process is assessing the individual at their own workplace rather than in the artificial environment of an exam. And once that case-based discussion happens, it's not that you have to wait for a few weeks for somebody to come and tell you that, oh, you were successful in that discussion. It happens there and then. So you have a case-based discussion, the candidate goes out, 5 minutes later they are back in, and then you have a conversation with them to say whether they're successful or not. Some of our colleagues had some difficulties because there were odd occasions where somebody was not successful, and so we learned through that process as well. How do you give feedback to someone who's not been successful? It's very easy to tell people that you have passed and you're successful. It's actually quite difficult to tell somebody that you haven't passed in that particular moment. So we did some work around that as well. And the whole process was more around an adult education basis rather than like a trainee assessment and examination process. When we went through the phase 2, so we looked into other medical systems. We looked at their quality of care available to those systems, their governance and independence, the comparability of training systems, their standards, integrity and reliability. So as you can understand, to give an example, in India, MD as a program is offered, I think somebody mentioned, in around 250 medical colleges. And I'm pretty sure that the training program standards are quite variable depending upon where you do your training. Not only based on the duration, but also the availability of faculty, how long the program has been running. You know, the training program in a medical college is just started in last 2 or 3 or 5 years is very different than what has been going on somewhere for 30 or 40 years. We also looked at their performance in terms of ongoing medical education and their practice standards, and also a cohort analysis in terms of how the group fared with the college standards. There have been, the pathway isn't necessarily without its problem. There are lots of problems about it, in a sense that some people said, well, it's an easy way through. I had to go through a very difficult exam, and now you're just letting people go through with a very easy system. But when we looked at our data, what we've observed is that it's very consistent in terms of what their performance in the examination system was. So that issue about not having exams was something which was an issue for some people. There were certain countries where we had difficulties in terms of getting some sort of clarity around their medical system. There were places where there were no formal external reviews of the programs. In terms of an accreditation agency for the training program or an accreditation for the hospital or the health service, there are certain number of people where we do not have enough numbers to compare with our existing resources. So for example, occasionally we will have somebody who will come from a country where we had never had an application from. So that becomes a bit of a difficult issue for us. There's always a possibility that that somebody is actually quite good, but occasionally the cohort performance does impact on the overall performance. And then there is really no accepted method of performing international comparison of training. I've had some conversations at this conference with colleagues from UK and Canada to actually look at our assessment of overseas trained psychiatrists and whether those processes are similar or different, but really there is no other accepted method anywhere else to look at that. So as John mentioned, there are obviously 3 pathways. You could be substantially comparable, and then you go on to a supervised 12-month workplace-based assessment. You could be partially comparable, which is at a lower level, which is more like a registrar level experience, or you could be not comparable. So if you're not comparable, you are guided towards the Australian Medical Council examination process, and you're encouraged to apply for the training program. So our second largest cohort, besides substantially comparable, is partially comparable. So I would say most of the people who are partial comparable pathway are the ones who've done an MD for 3 years, and they might have done 1, 2, or 3 years of post-MD experience. They don't necessarily have a specialist experience beyond that period. And so that cohort generally is exempt from stage 1 and stage 2 training, so they don't necessarily have to do what we call as training, but there might be certain gaps in their training. So we see a lot of people who've done either no child psychiatry, for example, a lot of MD candidates who've come from India, quite a few programs do not have any dedicated rotation as a child psychiatry, whereas there are some who have had a 3 months or 4 month experience in child psychiatry. But there are people actually who have missing or gaps in their training. So they might have to do that training in addition to a few other things. They might be exempt for an advanced training. For example, if somebody has done 3 years of MD and they've done 2 years of senior residency, they would be exempt for advanced training because senior resident experience is very similar to an advanced training. They might be required to complete an exam. It's quite interesting what we found through this process is that there are qualifications in different parts of the world where there are no exams. So there are some European qualifications where they haven't had any exams, no written exams whatsoever. They've done a 3 or 4 or 5 or 6 years program and they have had no exam. So we might have to say, well, if you haven't done any exam, we might have to ask you to do some exam. If they've had a gap with regards to psychotherapy, they might have to do that. Or if they hadn't done a scholarly project, then we might ask them to do that. And then they are also required to sit for an essay-style exam, an objective structured clinical examination, and psychotherapy and indigenous experience, which are minor parts of that process, especially psychotherapy, only if they haven't got that experience. If anyone in that partial comparable pathway, if they require more than 12 months of training, then we would direct them to a not comparable outcome. So effectively, when someone gets onto the partial comparable pathway, they've done at least 4 years of psychiatry experience, including their MD of 3 years or if it is of longer duration. So currently we've got 88 applications for specialist assessment 2019. I think the college does have all the numbers over the years. We haven't got those numbers here now. Those numbers are kind of fluctuating, but they have dropped a little bit. There are 110 people active on specialist pathway, 27 substantially comparable and 83 partially comparable. In 2019, out of all the assessments, 1 from India was substantially comparable, 15 were partially comparable, and 4 were not comparable. So that is out of 20 people over that 2019 period. That is quite usual what we've seen in the years in 2017 and 18 as well, because vast majority of people who migrate from India to Australia, they migrate within their 6 years of starting their MD. And so their experience is not senior enough to be substantially comparable. Whereas majority of migration of psychiatrists from UK to Australia are the ones who've actually got their MRC Psych and CCT and they've worked for 2 or 3 years or 4 years as a consultant psychiatrist in UK before they migrate. So we've certainly seen those patterns that people who migrate from UK are more likely to be substantially comparable, whereas people who migrate from India are more likely to be partially comparable. The other interesting thing about this thing is now we know where people are. So there was a period before 2007 where we didn't even know where the overseas trained psychiatrists were. Now, if we do not know where you are working, we cannot help you. And there were people who've been working for 3, 4 years, not having adequate amount of supervision, not necessarily taking the exams, waiting for some miracle to happen. And there was no contact with them. They were not in contact with other colleagues sometimes, or they just postponed or decided not to take the exam. And for them, the clock was ticking from the medical board, because medical board eventually would come to you and say to you, we will not extend your registration because you're not progressing. So when John took over that committee and when we did this work, our first task was to find every single overseas trained psychiatrist in Australia. And we also looked at New Zealand, but New Zealand has got some certain different processes. But our first step was to find every single person. So as of now, we know every single psychiatrist who's come from overseas. The college is aware of where they are. And we've done quite a bit of work in terms of what systems need to be put in place to make sure they receive the kind of support and supervision they require. It was and it is in our best interest that those people actually progress. Because we've seen the impact failure can have on people, not only professionally on them, but also personally in their lives. There have been a number of inquiries in Australia about overseas trained doctors. It started with 2012, Lost in Labyrinth. There were 45 recommendations to reduce red tape by different organizations, regulatory bodies, and including colleges. There has been some subsequent reviews. by the National Registration Accreditation Scheme. There is a good practice guideline for SIMG assessment by the medical board. And most recently, 3 years ago, there was a review by Deloitte of each of the colleges' process about assessment of SIMGs. So there's quite a bit of focus, not only it started from a parliamentary inquiry, but there's quite a bit of focus from the regulatory bodies and the Australian Medical Council on all the specialist colleges in terms of how the specialist international medical graduates are assessed when they apply for that assessment process. And there is a more consistent approach in assessing overseas trained doctors currently than what it was, let's say, 10 years ago. So that there is a significant impact on all of the colleges, and that includes our college as well. We offer a lot of support programs and resources for IMGs. So when we first looked at this issue, and when we found that there were people who were not passing the exams before this new system came in place, we started some exam preparation workshops, and John was the architect of some of those workshops, which kind of we ran that workshop twice a year, and we made it mandatory for every SIMG to actually attend one of those workshops so that they knew what was being expected of them in the exam. I was having a conversation with a colleague earlier in the day, and most people who migrate to other countries, they have to get a driving license of that country. And I've had that conversation with overseas trained psychiatrists who come to us. I work with a lot of them in my clinical role. And some of them are unhappy that why maybe being assessed, and maybe I shouldn't need to be assessed. And so we have a conversation with them about a driving license. Because once you lived in a country, you migrated, and if beyond a year of international driving license, you have to take the local driving license. And so I asked that question from them, what happened to your driving test? Did you drive as you would drive in India, or did you drive as you would drive in Australia? And that was an eye-opening exercise for a lot of people. To have that sort of comparison, that you have to understand a system and you need to perform in that system in order to practice psychiatry or any other specialty for that matter, is actually quite important. The other example which comes to my mind, again, I was talking to Dr. Carr, if I was to come back, and I think there are some of our colleagues who mentioned that, you see a patient here and you give them a choice, then do you want me to start on this SSRI or that SSRI? Patients have actually said, well, the doctor doesn't seem to know what they are doing. They're asking me. So there is a cultural context to where you practice. You know, whether you are involved in shared decision-making with the patient, how much of that is to be done, what is culturally accepted in that environment, is actually quite relevant. And I think that's where our focus was, to make sure that the people who migrate, we provide support to them so that they can practice psychiatry as it is practiced in Australia. And I think that has been a significant impact in not only in their own practice, but also how they've been then able to contribute back to their own country of origin. So we run quite a few programs. We've had some clinical practice skills workshop, which focuses on interviewing, psychiatric interviewing, and how to interact with other people in a multidisciplinary environment. We provide quite a bit of information to them about adaptation to psychiatry in Australia. In fact, Commonwealth government put a website together, what is called as Doctor Connect, which gives lots of resources to doctors who migrate to Australia, irrespective of whether they are specialists or non-specialists. Our college did quite a bit of work on remediation, so we spent quite a bit of time, resource, and money on helping people improve, including providing one-to-one coaching to them to help them pass their exams, and in addition to the local training programs. And of course, there are courses which help people prepare for the exams and assessments. So especially for the partially comparable people who have to do a written exam or they have to do the OSCE, there are lots of resources available to them. Some of them are offered by the employers, some of them are offered by independent providers, and the college provides some support to that program as well. So the college has had some certain challenges, and really, if you look at the medical board, what is the purpose of medical board? And a lot of people say, well, the purpose of medical board is to support the doctors. Unfortunately, in Australia, the purpose of the medical board is to protect the community. To support and help doctors does not come in their ambit. Their ambit is to actually protect the community. And so, similarly with colleges, it is important that we make sure that the standards and public safety are properly maintained, and we can actually defend our decisions. We cannot do that without doing a real practice assessment. The processes are obviously different in New Zealand to Australia. So we've got more than 50% of psychiatrists in New Zealand are not fellows of our college. Quite a significant number of them are affiliates of our college. The New Zealand Medical Council doesn't require them to be a fellow of the college or go through that process. So some of them do it and some of them don't do it. And that's a challenge which we continually face, and how we make sure that bring them into the fold of fellowship. And not only that, but also to offer continuing professional development opportunities to that group. John alluded to the ethics of all of this. We're not here to recruit, certainly not. I am an employer, and we recruit quite a few psychiatrists from different countries, but that's not really our purpose. There's been some discussion in different forums about brain drain versus brain circulation. We've had some conversations with the IPS in the last few days, and quite a few other colleagues as well, in terms of how we can contribute back to the country of origin. And that applies to all overseas trained psychiatrists in Australia. Quite a few of them I'm aware of, they do things at their own level. Quite a few of them run some training programs. Some of them go and there are people who are honorary faculties in different universities, so they spend a week or two when they return back to their country of origin contributing to training and education. So all of that is happening. Obviously, when the process started, there was issues about discrimination against individuals. So there are different colleges have faced that issue, where people have said, well, I have been discriminated against because I'm an overseas trained specialist rather than a locally trained specialist. People have looked at data in terms of the performance of locally trained trainees versus overseas trained specialists in examinations. So that is something which we are very, very aware of. And obviously the cultural imperialism aspect of it. And really, I think our effort is to how do we give back, especially when we know that migration patterns of workforce are quite interesting over the last few years. And it is not restricted to psychiatry. In fact, psychiatry is not the top branch in terms of migration patterns. There are quite significant patterns of migration on general practice, anesthesia, as well as some of the other non-surgical specialties. There is an opportunity for short-term training. So basically, it's a separate pathway which has been there for a little while, I would say in excess of 20 years, which has been utilized by a number of people, where they've taken the opportunity to have 2 years of training or advanced training in Australia. The College of Psychiatry in Sri Lanka has been actually quite effective in using that. So they've had for a period, mandatory period, where they had to do their 2 years of training in a country outside Sri Lanka. So a lot of people went to UK or they went to Australia. But obviously, what happens is when people arrive, they make a decision at a later stage what they want to do. But certainly that process is available. So for that process, the specialist doesn't have to do any AMC examination process or a comparability assessment. It's not a pathway to the fellowship. The maximum time granted to them is 2 years. And once they've done the 2 years, they can return back to their country to finish their specialist training or return to work. What that pathway does is allows people to get additional experience in areas which is not easily available to their own country of origin. And we see still quite a significant number of people who utilize that pathway, and they finish their 2 years and they return back to their country of origin. I think that's an interesting process to kind of cross-cultural aspect of training in different countries. And lastly, our college, our annual conference we should say about the annual conference in Hobart first. So our annual conference this year in 2020 in May is in Hobart. I know that some of you will come to Hobart. It's a beautiful place. But simultaneously, we also want to take the opportunity that the college is conducting an International Congress of Psychiatry in Singapore in 2021 from 9th to 13th of May. And we've had conversations with IPS and the College of Psychiatrists in Sri Lanka as well, and a number of other organizations, including the college in UK. And we would want a large contingent of you to come and support our Congress. And we'll work with the IPS to develop and have some sessions, joint sessions with the college and IPS. So we hope to see many of you in Singapore. Thank you.
Thanks, Vinay. I'll just finish up. Just to say that the college in Singapore is also very supportive, and we're working together as an international conference here, of course. When I first went into this business in 2008, a lot of overseas psychiatrists were very demoralised and were second-class citizens in the psychiatric world. I set out to change the system so that we would actually be able to come and hold our heads up here and say that we're doing something correct for people rather than wrong for people. Now that we've actually got a better system, we are very keen to work with the IPS about how we might share some of that knowledge and how we might be able to help people to give back and to do that. Because one of the things that I learnt that was most important in this was that when my colleagues came from overseas, I learnt much more than I taught them. They had experiences and knowledge that were different to mine, but important to mine. And they would say they thanked me for the things that I did to help them get the fellowship, but I thank them for what they did for me. So we want to look at it this way. It's not one country taken from another, but how do we give back and work on it? So thank you very much.
Thank you, John and Vinay, for an excellent presentation. In fact, training in psychiatry in the Royal Australian New Zealand College is a matter of great interest to Indian psychiatrists and the members of the IPS, because as you have rightly shown, many of them you do come to Australia for training or job, and this has been a very interesting topic. We are very happy that you have many programs like support systems for the persons who are going to undertake RNCP examination, as well as the SST program, which appears very interesting. I'm sure our younger colleagues have noted that. And I have one question to either John or, because at least a couple of instances, I have noted that about 20% of the persons from India, probably international medical graduates, they did not appear to reach your assessment showed that they lacked comparable training. Whether this is an arbitrary, because at least 2 instances have come to my attention when I was requested to take it up with RNCP, but I thought it was not a right thing to do. So I did not know, but I wanted to tell you now, because in India, every examination is conducted by the respective university. And all MD courses, if it is held, it is granted by the Medical Council of India, and it is also approved. The final examination, the degree can be given only if the approval from the Medical Council of India is available. So how does it compare when you say that in one institute it is good and the other institute is not good? Maybe under the same university, under the same medical council. And it was brought to my attention that RNCP has not made any special inquiries. They have just looked at their the CV or which is the training program is everywhere the same. So I just bring it to your attention, and maybe if there is some correction needed, maybe you can look at it.
2 things. I think that you're right. It's very hard to judge somewhere overseas in terms of quality. So we did 3 things to try and safeguard against that. One was that we set a set of standards for every country, which was that if there was external review of that exam process, we gave that a good mark. And we set up a system where all the things had different marks. And so that got a good mark for doing that. But if that person had been out and practicing and had done good practice, even if we said that that qualification hadn't been externally assessed, they might be able to get very good marks for that section. So we set it up so that if you were a very well qualified psychiatrist, practicing well, publishing well, you would get enough marks to do it. So there was a compensation system, because it is very hard to do that. If you I remember conducting a telephone conversation with a dean in a Caribbean city, trying to understand what the way they train their psychiatrists. Very difficult for all reasons. So you're right, we need a closer association so we can refine that. But I also think that would be good if that was a little more global. So it wasn't just us doing that maybe you could contribute and you could tell us. What we did informally is we went and asked colleagues like Vinay, which are the best institutions in India? Which ones should we model our assessment on so that they will be successful? We treated a little bit like that. So yes, but very hard.
We are very happy that you are quite open and receptive to such ideas. Thank you very much. I'm sure there will be some more questions and comments from the audience. Yes, Manan Karre is very dynamic.
He's going to tell us about that.
Person.
No, I got up because I've just done the SCP pathway. So I was in that cohort which started in September 2018. So I moved from the UK, and I must tell you that at first glance, when you look at the paper, there's only one country who does more paperwork than India, I think, and that's Australia. My God, they can do paperwork. But once you go through the process, it actually flows quite smoothly. Those case-based discussions, they are very collegiate. So you have other psychiatrists who talk to you about something that is in your practice, and it's very relevant. The discussions are very relevant. So I remember that in the first case, or in the second case, the discussion that I had was about driving licenses, because the person was on quite large doses of psychotropics, and there are very different regulations in the UK compared to the driving regulations in Australia. So as Vinay was saying, it's contextualizing the care that we are giving to that setting. Also, the other big difference, I think, which I felt particularly when I went from India to UK, but also there are cultural differences between UK and Australia. In the GMC, there is the first clause, make the care of the patient your first concern. It might seem like something very simple, but when you try to translate that into actual care, it may not be. And even in developed countries like Australia, your first concern might be to clear all the patients who are in the emergency department. And you start losing focus on care. And what I found in those case-based discussions was the discussion very much centered around, are you making the care of the patient the first concern? And are you providing person-centered care? And that's quite a mindset shift. And that is for me, who had spent 18 years in the UK. I trained in the UK and worked in UK in a couple of prestigious organizations. So even then, there are cultural differences. So I think that contextualization is really, really important. The other thing is documentation. So I did my, I would have done my psychotherapy long case in 2003. And I was doing this substantial comparability assessment in 2017 when I didn't have any of that documentation, which I had done in 2003. I never thought I would migrate anywhere. So kind of those things can prove really challenging. You have to do 40 sessions of attempted a 40-session long psychotherapy case. So for those who are postgraduate trainees and are thinking of going there after 2-3 years of postgraduate training experience, it's important to hold on to the paperwork relating to your scholarly project that you would have done, any psychotherapy experience, because you have to provide that as evidence. Because it would be the same if someone wanted to come and practice in India and they had an overseas qualification, we would want to see the evidence that they have. So in a very similar way, Australia asks for evidence, and that can at times prove challenging if you have not kept the paper records of the training that you had done many moons back.
You can see some young faces, PG residents, exam-going PG residents. Would you like to ask Dr. Derek Johnson? He's a final year exam-going PG resident from India, maybe potential to Australia. What do you want to ask?
Thank you, sir. I would like to ask one question. In the table you did show, majority of them, they did not stand up to the standards of the assessment. What happens to them? Do they get re-evaluated again, or?
What happens to that?
what happens to the
The candidates who did not attain the standards.
who did not succeed? Okay, okay. In the pathway or in the assessment process?
Assessment process.
Assessment process. So, you want to answer that?
Oh, I think you know the answer.
Yeah, I do know the answer.
Answer if you like. It's too hard for you. So for those who don't succeed, they might go to a lower pathway and go back and do some more training, and then go and do an exam process for those few who failed in the substantially pathway. For those who get on the partial pathway and don't pass exams, then they might end up in either the Australian government might withdraw their registration because they say they should be progressing, or they might end up in a lower grade work as a medical officer rather than as a consultant. I think in the past that was quite a tragic outcome. Today we try to make that less and less, but it's still a problem around standards.
Thank you.
What we've noticed is that majority of the people with the right kind of support can actually do well. And there are two things. One is in the assessment process. Vast majority of the people, when they apply to the college, when Dr. Carr would have applied to the college, he would have anticipated that he'll be substantially comparable. Because there's a lot of information, checklists on our website. So you already know where you stand because you've kind of looked at all those criteria. It's a very transparent process. So 90% plus people actually get an outcome what they know they should be getting. There's only a very small proportion of people who get an outcome which is different than what they anticipate. And for some of them, it becomes a challenging exercise. Some of them use the process to appeal and whatever, and then the outcome can obviously change. And similarly, for once they've gone through the examination process, and if the outcome is different than what they anticipate, then there is a fairly transparent process for them. But those numbers are very, very small. We haven't really seen large numbers of people not succeeding in the process.
Thank you. Thank you very much. We know that it's a very transparent process. There is no complaint about that. Very good. Thank you.
I'll just add one more comment to that. I think 15 years ago there was enough support for people, and someone who failed might interpret that failure as racism. I thought that they didn't like that overseas doctor. And I was really quite appalled by being part of a system that would allow people to think that. So we set out not just to the pathways, but to make sure we had the support for people to be able to succeed. Yeah.
Thank you. I can see the former president of the ANCIPS, Malcolm Hopwood. Would you like to make a comment? Yeah, please. Please.
Well, I don't have a lot of comment, and I acknowledge that both John and Vinay have contributed to this area enormously. I think it's interesting to think what are the common questions that people have in anticipation of applying to come to Australia and New Zealand. And I think John and Vinay have described very well the importance of getting an expectation before coming of what are the hurdles I might have to go through. I think one of the other questions that often comes up is, if I have to go through an examinations process, how long have I got? How long does it usually take people to get through that? And how long will the Australian authorities allow me to practice before they'll start to say, well, you're not progressing? And I don't know if you want to answer that, Vinay. You're probably in a better position than I am.
Well, you've asked a difficult question. I do have an answer. So the medical board, and this is not new. So this was in place when I migrated in 2004. When the medical board first gives registration, even at that time, they said, you've got 4 years to attain your specialist qualification. They did not necessarily implement it as effectively as they should have. And that still kind of remains an issue. But they are becoming more stringent about it. Because what we have noticed and what they have noticed is that when people stay longer and they are not successful, it has lots of impact on them. Failure has impact on them personally, professionally, financially. They've got kids in school, so it's a very difficult process. So we want people to succeed early rather than for them to kind of stay for a longer period of time. But 4 years is what they say. And they're reasonably, if somebody is progressing, because I think they have emphasis in for people to learn and improve, then they are flexible sometimes to allow more time to people.
Thank you very much. This is very, very clear clarification. I think that was the last question. AGB has to start now. Yeah, last question.
Thank you, Vinay and John, for presentation. I just wanted to add, and I'm also one of the uh, person who went through the pathway when it was expanded in 2014 to other countries. So that was when it was expanded to all the countries in the world, way back in 2014. Now, sometimes, what I want to say, and I'm in that committee as NZ representative, uh, the process is quite evolving. So as we go on, we keep on refining that process. And sometimes candidates do get disappointed because of the not getting the outcome they were expecting. So, and that's because sometimes, because the process is dynamic, you know, you get different outcome, even if you have quite similar training, because the criteria has also changed. That's what we have observed with few candidates in last 1 or 2 years. So that's also to take into account.
Different outcomes if you
Thank you very much. Now I will hand over to my co-chairperson, Prasanjit Ghosh, for his concluding comment.
Thank you, sir. Thank you, Professor John, Professor Vinay, for such a nice presentation. I work in Silchar Medical College, which is a very remote part of this country in Assam, where we send our PG students regularly for 2 months training in child psychiatry at NIMHANS and 1 month training in neurology at Guwahati Medical College. And I'm pretty much sure that most of the medical colleges in India have child psychiatry training in their curriculum. And second part is, I think joining of hands of IPS and RNZCP will be beneficial for members of both the society and as well as the patient community. Thank you for joining our annual conference.
Thank you very much. Thank you.
Thank you very much for the excellent. Thank you. We'll conclude with this. We'll conclude the session.
I would like to request our chairperson to honor our speaker, Dr. John Allen. Yes, sir, please. I would like to request Dr. Mrugesh Vaishnav, sir, to honor our chairperson, sir.
We are waiting.